little earlier. So where to place the ologen? Again, just better to place it more posteriorly than anteriorly, because once you are using a fornix-based flap, and if you are not going to close it properly, then there is a possibility that it can get exposed because of the lid movements, especially when they have a good ocularis. Then there is a possibility that the ologen might migrate more anteriorly. So it is better to place it a little bit more posteriorly than anteriorly. What is the size? I really don't know at this moment. Probably Dr. Bobridge and others have suggested to use 12 by 1, but we have used 6 by 2. That is the results which I have shown you. But when you have more number of cases, I used to use 12 by 1, cut it into 2 halves, and then use in both the patients. That is the way we do it. When you are closing the conjunctiva, I just wanted to give one more practical tip is that don't take the sutures through the ologen. It is better to avoid, because once you take the braided A-to-Y krill, what happens is there is a migration of whatever the external things are there through the ologen, and then it causes possibly an infection. So it is better you avoid taking the bite through the ologen when you are taking the conjunctival closure. This is a small video clip. Probably I'll just show this video. This is the releasable suture. We use this type of a releasable suture. There are so many different types of releasable suture one can do it. We use a single releasable suture with a 10 nylon. Just form the chamber, and this is additional suture because this is a juvenile open-angle glaucoma where the flap is much more fragile, and also the closure is little difficult. Definitely in a congenital glaucoma and in juvenile glaucoma we need additional sutures than the adult glaucomas, because the flap is not the same. The closure is little difficult, and also it is more leaky. So you can close the conjunctiva nicely. On both the sides, the wing sutures you can apply and then close it nicely. Or sometimes you may feel the chamber is collapsing all the time, there is a excess leakage. You can put additional releasable sutures, as I've already mentioned to you. Instead of 1 sutures, you can put additional either 2 sutures you can use, or sometimes 3 sutures. But then it is better you remove it little earlier than leaving it later. By at least 2 weeks, you must remove 1 or 2 sutures. But 1 suture at a time is always better than removing all the sutures at the same time. By 3 weeks or 4 weeks, even if you remove all the sutures, nothing is going to happen. It is still safer because the ologen is there as a tamponade. You don't have to really worry about the leakage part at the end of 3 or 4 weeks. So what are things that we have practically again understood is when you open the pack, you just make sure that the ologen is in the proper shape. Sometimes we have seen 1 or 2 packs, we have seen it as more like a paper. So better not to use that. It probably got exposed, so it is more appearance to be a more papery tissue. But you have to just check it and then use it. And also, if you want to avoid the ologen, probably this is a porcine material, some patients might have an allergic reaction to that, so you have to make sure that. Or when you have a very non-retractable conjunctiva, then it is better to avoid ologen because it is going to have a height of the bleb is going to be a little bit more, or you might have exposure at the limbus. So this is a problem. And also, if you have a complication with the other eye, we had a couple of patients who had erosion with the ologen. So that is also you have to be careful. So in those cases, you better avoid the other eye ologen. So some of this is the exposure we had in 1 patient. And this is the endophthalmitis in 1 or 2 patients we had. But both the patients were treated appropriately and they were doing quite well. This was, we have to put a patch graft, and this I had treated with the regular antibiotics like regular for endophthalmitis. Where we used ologen, mostly where we had problems with the mitomycin, that is where we had indications. And some of the juvenile glaucomas and secondary glaucomas like especially those with eye syndromes, aniridias, where we started seeing more of astigmatic changes with the mitomycin. Once you use mitomycin, the astigmatism, especially when the mitomycin is more reactive, there is a constant change in the cylindrical powers in quite a good number of eyes. So where we used in those patients also, so it gave quite a good results. Young myopes, high myopes, with the scleral thinning, all these patients, refractory glaucomas, we have used with a quite good results. With these few practical tips, I hope it is useful for you to take back home. Thank you so much. Any questions, please? Initially, we had a little bit of difficulty because we were a little scared to put the sutures, loose sutures. And when we started putting more tight sutures, again the problem is the IOP will be high. So you have to be very careful in the suturing technique especially.
I have just one question about the patient with that endophthalmitis. And did you remove the ologen implant? Well, you said you put a patch graft. Did you remove the ologen?
No, the patch graft, we did it for the patient who had erosion over the ologen. But that patient did not have endophthalmitis.
Okay, it's only exposed and exposed.
Those two patients had the exposure, and we have used mitomycin also in those two patients.
Okay, and the other patient with endophthalmitis, you didn't remove the ologen, just treated antibiotic?
Yes.
Okay, thank you.
This will dissolve in how many days?
In juvenile glaucomas, it appears to be disappears a little quicker than the adult glaucomas. Probably by 1 year, we haven't seen much of ologen staying there. By 1 year, 3 months, almost none of the patients had any ologen over there. But 9 months, 6 months to 9 months, in most of the cases, it disappears. By 9 months, it is almost like most of the cases.
Thank you. Okay, our final speaker is Dr. Rao. He's going to talk about using ologen in developing countries.
Good morning, everybody. Thank you, Paul. The epidemiology of glaucoma in India is slightly different. The prevalence of the studies have shown that the prevalence of primary open-angle glaucoma occurs in 3.5% of our population in more than 40 years. And the problem is 90% of the primary open-angle glaucomas are undiagnosed. And the late presentation of disease and poor IOP control due to lack of awareness and compliance and socio-economic issues are major problems in our region. If you look at this study, which shown that the primary open-angle glaucoma, the patients presenting at the time of presentation, they have blindness of almost 20%, and primary angle closure glaucoma, the blindness rate is almost 40%. High cost of long-term medical therapy and poor access to medical care and economic issues are reasons we need to address in this area. So many of these patients would need early surgery as a first choice in the management of glaucoma. As you are all aware, that trabeculectomy introduced in 1968 is probably the gold standard, and we have got many modifications to enhance the success rate. Mitomycin has been around for more than 20 years, and we are all aware of the problem of mitomycin. It goes with thin blebs, overhanging blebs, and the problem of choroidal detachment, shallow antechamber, and hypertonous maculopathy as shown here. And cystic bleb causing discomfort and blebitis and endophthalmitis as shown here, or overhanging blebs like this are problems which can expose the patients in this area to endophthalmitis, which would be a disastrous thing to happen. Like endophthalmitis, especially if the inferior blebs are shown here. And the bleb leak which occurs can allow the bacterial pathogen to create a hole and enter the eye. So this is something you should keep in mind whenever you use mitomycin. So if you have a patient who has got a thin bleb like this, which is more likely to have endophthalmitis, bleb leak as shown here, or a spongy, diffuse leak as shown here, can produce. And as with any other surgical procedure, scarring of the bleb can occur even with mitomycin and poor control of glaucoma, as shown here. So what we knew is studies have shown that adjunctive use of mitomycin. There have been some studies from India, one from Aravind Hospital, which has shown that the long-term dose response of mitomycin has been studied, and it has been shown that patients who use mitomycin for longer duration have better IOP control compared to patients with shorter duration or without mitomycin. But there is a trade-off. Whenever you use mitomycin for a longer duration as shown here, the non-cataract complications are higher, and The cataract progression is also higher with a longer duration. So you have these trade-off whenever you use mitomycin. So the use of ologen is probably another option which you should consider, and we are all aware what ologen does whenever you use it trabeculectomy. It's a type 1 active collagen, as mentioned by earlier speakers, and it acts as a dry scaffold. So the advantage is that whenever you use ologen, we need not change the technique. You stick to your technique. You can also use a releasable suture, which is what we use, and also it's safe as phonics-based flap, unlike mitomycin, which is likely to leak more often. So the way we use is use a limbal-based flap as shown here. After you bury the side knot and one releasable suture, you put ologen on top and use a 80 vicryl running locking suture to close the conjunctiva. We put it on top. Earlier we using we still use 6x2 as shown here, and use a running locking suture, and we have put 2 releasable suture because this patient had pseudo-exfoliation glaucoma with earlier failure of one surgery. So the advantages are, we are all aware that how it maintains the space and it acts as a scaffold for the fibroblast to go through, and also it prevents early hypertonic because it prevents the flap from leaking. The advantage is there is a faster high related wound healing, and there is less contraction of the wound, and there is no hypotony which is seen often with mitomycin. So the only problem which you used to see in the early stages was when you used to put ologen more anteriorly, we used to get Dellen as shown here in a patient with juvenile glaucoma, and also shallow chamber, but these are managed conservatively without no need to do reformation of the antechamber. There was one patient whom we had a late biodegradation, which took almost 6 months, but ultimately ended up in a good bleb. It's a patient pseudophakic post-trap, and ultimately ended in a pressure of 12 with no medication. And the patient was early post-op with a beautiful diffuse bleb with a well-formed chamber and a releasable suture. And this is a patient 3 months post-op who had a good bleb. This is a typical mitomycin bleb we see in juvenile glaucoma, whereas we get a nice healthy blebs as shown here. This is another patient. This is actually a patient who has now completed 3-year follow-up, juvenile glaucoma. You can see the patient is wearing contact lens to restore the vision. This is another patient with refractory congenital glaucoma, which typical severe Stevens-Johnson-like syndrome, typical ocular surface disorder with stiffia vascularization, aphakic eye, vitrectomy done, rectal attachment operated, and multiple surgeries, got multiple staphylomas, and post-operatively he ended up in a good bleb, a clear cornea, and also pressures of 10 without medication. And typical pseudophakic bleb in a patient with ologen. This is a patient who has one-eyed mitomycin trap and other eyes sort of ologen. You can see the difference in the appearance of the bleb between the 2 eyes, and the pressure control is much good. This pressure is not hypotonic, but pressures of healthy 10 millimeters of mercury. Basically, we have with ologen, we have a regenerative approach to the wound healing, which because the highly porous scaffold provides spacious biological binding sites for fibroblasts, which enables scarless, healthy tissue regeneration. Whereas mitomycin C is a cytotoxic approach which produces cell death and apoptosis, which results in scarless wound healing but with thin avascular epithelium, which could be risky for long-term control. We are yet to develop an ideal glaucoma surgery. We are still working on it. The keys to ideal surgery is to allow an ability to understand the control, the 2 processes, the aqueous outflow, aqueous inflow, and the healing process in the eye. Ologen probably may be preferred when antimetabolite-related complications are to be avoided, and it seems to be a very good adjuvant in trabeculectomy, and is probably a safe alternative to mitomycin C. Thank you very much.
Thank you. Questions for Dr. Rao?
I will add a note. The Islamic Council in Azhar, Egypt, approved ologen tissue implant to be implanted during surgery.
Wait, could you just send me that? Was Aziz there? Was
Yes.
Aziz there at the time?
Yes, yes.
Okay, so it's okay for Saudi Arabia and it's okay for Pakistan now.
Okay.
Good, thanks. Any questions for anybody? Any of the speakers? Questions for the audience? All right, thank you all for coming, and we hope you have a good experience with ologen.